Hello, and welcome to today's discussion on stool culture workup. Someone's got to do it, at least for now. My name's Yvette McCarter, and I direct the microbiology laboratory at UF Health in Jacksonville, Florida. For today's presentation, I have no financial disclosures, and I will not be discussing any off-label product uses. The objectives for today's presentation include listing the organisms most commonly associated with bacterial diarrhea in the United States, describing emerging bacterial pathogens associated with diarrheal disease, discussing appropriate specimen collection, transport, and processing for stool culture. We'll also discuss methods that can be used to streamline culture workup, and we'll discuss appropriate antimicrobial susceptibility testing and culture reporting. Lastly, we'll touch briefly on the elephant in the room, that is the impact of nucleic acid testing on the performance of stool cultures. So let's talk stool cultures. Much of the information that we'll discuss today has been published recently this past January in Clinical Microbiology Reviews, and it's the laboratory diagnosis of bacterial gastroenteritis. So what is the impact of bacterial gastroenteritis? Well, globally, it's estimated that there are more than 1.7 billion with a B, cases of diarrheal disease reported annually, with 22 million deaths. It is actually the second leading cause of death worldwide in children under 5. In the United States, the impact is a little bit lower, estimated between 200 and 375 million episodes of diarrheal illness annually, with 1.8 million hospitalizations and 3,100 deaths. Also, there are 48 million cases of foodborne disease, with 128,000 associated hospitalizations. So, inquiring minds want to know, which bacteria do you think has the highest incidence of foodborne disease? And also, which do you think has the highest association with outbreaks? Is it Salmonella, Shigella, Campylobacter, S-Tech, Yersinia, Vibrio? Let's see. Based on information that was recently published in the MMWR by FoodNet, Salmonella has the highest incidence of organisms causing foodborne infection, but most interestingly, the highest percentage of infections, or the highest percentage of infections associated with outbreaks, are associated with Shiga toxin-producing E. coli. So when is stool culture indicated? I mean, for pretty much everybody, it's a self-limited disease, right? And so if you look at information from the American College of Gastroenterology and the Infectious Disease Society of America, we want to do stool culture primarily in patients with severe or prolonged diarrhea, those with evidence of invasive disease, for instance, people with fever or white cells or red cells in their stool, or people who have a complicated course. Now, from the public health perspective, it's important to do stool cultures because these are what our public health colleagues use, the isolates, for identifying and tracking outbreaks of bacterial gastroenteritis. Let's discuss specimen collection and transport. Obviously, you want to collect specimens during the acute stage of disease, usually within the first several days, in a clean, dry container, remembering that while they may be more convenient, especially for children, rectal swabs usually are less sensitive in isolating organisms. Transport is always important. If you're transporting fresh specimens, you really want them to get to the laboratory within 2 hours of collection, again, because your organisms do begin to die. That's why I recommend to everybody, if you can, since getting specimens within 2 hours often is not something that we can do, is to use a transport media. And that would be primarily a Carey Blair media. It's great because it's buffered, it has a low nutrient content. It also has things in it like salt and sodium thioglycolate to help preserve some enteric pathogens that we don't see very frequently, things like Vibrio, and at least in our area, Campylobacter. Also, it greatly increases your allowable transport time up to 48 hours for transport. Also, I've included in this slide something relatively new for you flocked swab users. There's actually also now a fecal swab transport media that's available, again, that also has Carrie Blair in the transport tube. Well, how can we optimize stool culture? One of the first things that we can potentially do is fecal leukocyte testing. Now remember, this is a screen for evidence of inflammation. Now remember, it does have a relatively poor sensitivity, though, especially in inpatients, for differentiating between infectious and non-infectious diarrhea. But a lot of times clinicians will order fecal leukocyte testing as a way to determine inflammatory versus non-inflammatory infectious diarrhea. So what can we do method-wise? We can use microscopy using either something like a methylene blue stain or a gram stain. Also, there are now cartridge immunoassays that detect fecal lactoferrin. Again, something else that I would recommend more so perhaps than microscopy, even though it is a little bit more expensive, primarily because the fecal lactoferrin assays detect a glycoprotein component of the neutrophilic granules. It's the best thing about it, though, is that it is more stable. These granules are more stable. You don't rely on the detection of intact neutrophils, and neutrophils, again, begin to disintegrate in stool relatively quickly once the stool is passed. So you do get a very sensitive and stable result with the fecal lactoferrin assay. Two important caveats to remember is that you can find lactoferrin in breast milk. So again, you can get false positives in babies who are breastfed. And also, the fecal lactoferrin assays are not FDA approved for non-stool specimens. So things like colonoscopy specimens would be inappropriate for testing with the fecal lactoferrin assay. Also, we can optimize stool culture by remembering the do's and the don'ts. The do's, applying the 3-day rule. Remember that there is a low yield of stool culture of isolation of enteric pathogens for patients who develop diarrhea after being in the hospital for more than 3 days. So again, you want to be thinking about something like C. difficile in those patients rather than the routine stool culture. Things that you don't want to do, again, if you receive your fresh specimens after a prolonged delay in transport, you really don't want to process those. You don't want to process your specimens received in Carrie Blair if they, again, have had super excessive transport delays, more than 48 hours. Or if you happen to be using a Carrie Blair with an indicator, a pH indicator, if that indicator has turned to acid. Also, really no need to collect or process multiple specimens in the same 24-hour period. So the next question is, which organisms do you include routinely in your stool culture? Salmonella, Shigella, kind of the top three. Salmonella, Shigella, and Campylobacter. Do you include Salmonella, Shigella, Campylobacter, and Aeromonas and Plesiomonas? Or perhaps instead of those, Yersinia and Vibrio? Or do you just culture for everything? Essentially, the things that we should always be looking for in every stool culture are Salmonella, Shigella, and Campylobacter. The other organisms, such as Aeromonas, Plesiomonas, Vibrio, and Yersinia, I consider kind of the sometimes organisms. We should be looking for these organisms based on where we are geographically in the United States, the patient population that we serve, and whether or not there is some potential for seeing those organisms on a seasonal basis. There is some selective media that we'll be talking about that can be used to help optimize recovery of those organisms. Now, the organisms that I've listed here as the never organisms, these are the ones that are very infrequently to never diagnosed by the clinical microbiology laboratory, sometimes being diagnosed by our public health colleagues. These include things like Bacillus cereus, Clostridium perfringens, Listeria monocytogenes, and Staphylococcus aureus. Now, you notice in the previous slide, one of the things that I didn't mention is looking for Shiga toxin producing E. coli. So then the next question is, do you routinely test for that in your laboratory? Do you do both culture for E. coli 0157 and testing for the non-0157 STECs? Do you culture for 0157 only? Do you do an enzyme immunoassay for the Shiga toxin only? Or do you not perform testing at all unless it's requested? So the question is, why do you want to test all stools for Shiga toxin producing E. coli? And basically it boils down to selective testing strategies often are not the best option and will miss Shiga toxin producing E. coli infections. So if you happen to be using blood alone in the stool as a selection criteria, we know that blood is not routinely present in patients with Shiga toxin producing E. coli disease. And we also know that other infectious agents can cause bloody diarrhea. If you're only looking for these organisms on a seasonal basis, perhaps only during the summer, while they are more common during the summer, infections and outbreaks have been reported year-round. Also, if you only happen to be looking for this group of organisms in children, while again the disease is more frequent in children, almost half of the isolates from, if you look nationwide, are from people who are older than 12 years old. So why both culture and testing for Shiga toxin? Basically, it boils down to that it's better to do both than to do either one alone. Obviously, the culture for 0157 is going to be important because it does have a high predictive value of a positive for severe disease when you isolate the organism. You also want to make sure that you can treat those patients very promptly. You want to avoid antimicrobial therapy, and you do want to treat with parenteral volume expansion to make sure that their kidneys don't become damaged. Also, obviously, recognition of this organism and culture is going to have an impact on potential public health concerns with outbreaks. Now, in addition to culturing for 0157, we also want to look for the non-0157 STECs because they do actually cause a relatively significant proportion of disease. So should we be screening all of our stools for STEC? Well, the current CDC recommendation says yes, and it's the simultaneous culture for E. coli 0157, as well as using something like an EIA toxin assay to pick up the non-0157 STECs. Now, if you're one of those laboratories that says, I really don't think that I have enough in my population of these organisms to warrant doing the testing, you can use a selective testing approach. One of the things that I would recommend, though, is that you really want to find out what the prevalence of the organisms are in your population. So I would recommend screening all your stool cultures for 12 months because you do want to get the seasonality in there as well to determine the prevalence. If it turns out that you have a zero prevalence or a very, very, very low prevalence, then it may be appropriate for you to choose a selective testing approach. However, if you're going to apply a screening criteria, I would suggest a combination of screening criteria, again, because it does make your testing more sensitive. If you want to read more about the pros and cons of screening for Shiga toxin producing E. coli, down at the bottom of the slide on the right, there's an excellent point-counterpoint that was published in the Journal of Clinical Microbiology in 2011 about this topic. So what about emerging enteropathogens? Okay, we do know that other less common bacteria can cause gastroenteritis. There's actually an excellent two-part review, again published in 2011 in Clinical Microbiology newsletter that has a lot of information about these new emerging enteropathogens. I picked the top 5 to talk about. That includes things like enterotoxigenic Bacteroides fragilis. I know you're thinking, oh my God, Bacteroides fragilis. How much of that is in stool? A ton, right? Edwardsia latarda, Escherichia albertii, Klebsiella oxytoca, and Providencia alcalifaciens. First, let's start with enterotoxigenic Bacteroides fragilis. It has actually been implicated as a cause of diarrhea in children less than 5 years old and a cause of inflammatory diarrhea in both children and adults. But there is conflicting information in the literature about its pathogenicity. It does produce a 6 kilobase pathogenicity island that encodes for a zinc metalloprotease enterotoxin. However, there are probably some additional factors that play a role in the infective process, not just the enterotoxin. Also, if you think about trying to recover Bacteroides fragilis from stool, there's no easy way to do it, right? No easy way that you can make sure that you recover it. Essentially, you can do culture using Bacteroides bile esculin agar, and then test for enterotoxicity using PCR, looking for the toxin gene. Or you can do a cell cytotoxicity assay looking for a cytopathic effect produced by the toxin in a human colonic cell line. But again, not something performed by every clinical microbiology laboratory. What about Edwardsia latarda? Well, we do know that it's associated with probably less than 1% of cases of gastroenteritis. The spectrum of disease can range from an asymptomatic carriage to a watery diarrhea to actually a frank dysentery. And that the people who are most susceptible to Edwardsia latarda, as we would expect, are those who are very young and those who are more elderly. Escherichia albertii has been involved in at least one outbreak of gastroenteritis, and it has been isolated from patients with gastroenteritis. It does harbor known virulence factors to cause enteropathogenic disease. The interesting thing, though, is that it's frequently misidentified by a lot of our commercial identification systems, which is probably why we don't, if you will, hear about Escherichia albertii causing infections more frequently. It can be reliably identified using 16S ribosomal RNA sequencing or by using MALDI-TOF. Klebsiella oxytoca has been reported to be linked to antibiotic-associated hemorrhagic enterocolitis in patients who are negative for C. difficile, but confirmation does require detection of the Klebsiella oxytoca cytotoxin. Okay. It's also been suggested that in addition to this more severe disease, the organism can also cause a more mild to moderate diarrhea. Lastly, Providencia alcalifaciens. Studies have linked diarrheal disease and outbreaks with this organism to things like foreign travel and consuming contaminated food. Most of the isolates causing disease have been recovered in pure culture or as a predominant flora, or in the absence of other enteric pathogens. So then the big question comes, should I be looking for these organisms routinely? And the answer is no. We do know that you can find some of these organisms in stool in the absence of symptoms. And as you can imagine, it's going to be difficult to differentiate a lot of these organisms from the resident fecal flora. So if you are either asked to culture or want to culture these organisms, again, it should only be after discussion with your clinicians to determine which patients are unique enough to warrant this specialized testing. Okay, once we have decided what we're going to culture for, what media should I use? Now, again, the media that you use is going to be dependent on the organisms that you want to recover, obviously, which is, again, going to be dependent on your patient population and the organisms that you routinely isolate. Listed the suggested media here, obviously things like McConkie, the selective and differential media that are specific for Salmonella and Shigella, such as Hectoin and XLD agar. Also the selective media for Campylobacter, selective media for E. coli ON57, and enrichment broth for Shiga toxin testing. Now, what about enrichment broth in general for recovery of Salmonella and Shigella? Do you include an enrichment broth in your routine stool cultures? Now, this again is primarily looking for Salmonella and Shigella. Do you not include it, or do you include it selectively in certain cultures? So the question is, do we need enrichment broth to help improve our recovery of Salmonella and Shigella? If you look in the literature, it's kind of mixed. Most of the literature that reports, yes, you do need an enrichment broth, were frequently done by our public health colleagues, and they may be culturing specimens, again, from patients who are asymptomatic, things like that. But from patients who are symptomatic, often the enrichment broth does not increase your yield of Salmonella and Shigella. What I would suggest you do is what we did at our institution, and that's basically review your historical data to see whether or not your enrichment broth is actually contributing to your recovery of Salmonella and Shigella. At our institution, we found that it wasn't. We did not recover any Salmonella or Shigella that we didn't get from our routine culture plates. And so as a result, we've discontinued the use of enrichment broth at our institution. Now, what about the media for Campylobacter? Most of us probably use the blood-containing media, such as Campy-CVA. Remember now, there is also a blood-free media. It's the charcoal cephaloperazone desoxycholate agar, which again is a charcoal-based agar, which some have reported actually has better sensitivity for recovery of Campylobacter. Remember, the media that you want to avoid, though, is media that has things like cephalothin, colistin, or polymyxin B, because these antibiotics are inhibitory to some strains of Campylobacter jejuni and Campylobacter coli, and they're definitely inhibitory to Campylobacter fetus. There are also studies out there that show that using a combination of media, including one that's charcoal-based, actually improves your recovery of Campylobacter, so that is an option as well. Now, what if I'm choosing to look for things like Aeromonas, Yersinia, or Vibrio? Well, we know that Aeromonas grows just fine on something like blood and McConkie agar, but it actually grows quite well on Cephsalodin, Ergosin, novobiacin agar, which is our syn agar that we routinely use for Yersinia. So you can inoculate a syn agar, incubate it at 35 to 37, and that could help improve your recovery of Aeromonas. Obviously, we're also going to be using the syn agar incubated at room temperature to improve our recovery of Yersinia enterocolitica. And remember that lower temperature incubation, that room temperature incubation, produces a more distinct bullseye-like colony on that media for Yersinia. And obviously for our Vibrio recovery, we're going to be using our thiosulfate citrate bile salt sucrose agar, or TCBS agar. Important to remember that there are a couple of Vibrio species, one that's now in a different genus, Gramantia holzii, and a Vibrio metnikovii, which can be inhibited on TCBS agar. So again, blood agar would be another possible choice for recovery. Once we've inoculated our media, now comes the actual stool culture workup. Most laboratories use some kind of an algorithm where they screen their selective and differential media looking for non-fermenting or the colorless colonies, as well as H2S producing colonies. They then use some kind of screening biochemicals, for instance, something like a TSI, a urea, and maybe a lysine iron agar or something like that, to help screen out those organisms that are not enteric pathogens, not Salmonella or Shigella. And then some laboratories that have a very low volume may choose to just go ahead and perform confirmatory biochemical or serologic testing directly from their colorless or H2S positive colonies. Now, the problem with this algorithm, as we all know, it has a relatively poor sensitivity because we end up doing a lot of work, a lot of false positive colonies for a relatively low yield, right? So what are some other options that will allow us to optimize our workup? And I would suggest the use of chromogenic media. Chrome agar salmonella is an example. It's a selective and differential media. Salmonella on this particular media is this very nice mauve color. And coliforms usually are either blue or green, or in some cases, other organisms are white. We evaluated this media in our laboratory and found that it significantly cut down on the amount of time that we were spending working up stool cultures, because these mauve colonies can go directly to biochemical and serologic confirmation without having to go through the screening biochemical process. It basically cuts a day out of your workup. And the vast majority of these colonies end up being Salmonella. There's lots of information in the literature, again, about the sensitivity of the chromogenic media compared to your regular conventional selective media like McConkie, XLD, Hectone. Perhaps one of the biggest studies that was done was by Deirdre Church and her group, published in Diagnostic Microbiology and Infectious Diseases. They looked at about 3,000 stools. And you can see that the chromogenic media had a much higher sensitivity, even alone, compared to conventional Hectone media. Also pay attention to the colony picks. This was how many times colonies had to be picked in order to work them up. And you can see that it was 880 picks if you were doing hectoin with selenite broth. And it went down, if you were just using chromogenic media, to 114. So again, you can see how much workload the chromogenic media cuts down in working up these cultures. Hardy also has a chromogenic media, the Hardy Chrome Salmonella Shigella, that facilitates, again here, this chromogenic media is for both Salmonella and Shigella together. Both produce a teal blue colony, and Salmonella also produces the H2S positive colony as well. There is also chromogenic media that's approved in the United States for E. coli 0157. Again, much more selective than your conventional sorbitol McConkie. And again, your E. coli 0157 are the mauve colonies that can go straight to identification and serologic workup. There is also a research use only media, chromogenic media, for S-Tex in general, okay, more than just 0157. Again, it is just a research use only media, but it does detect other Shiga toxin producing E. coli as well. Again, lots of information in the literature about the increased sensitivity of the use of chromogenic media for E. coli 0157. Now, what about the use of MALDI-TOF to optimize our stool culture workup? If you look in the literature, this is a cost-effective alternative to screening all of your colonies and doing biochemical testing before identification. MALDI-TOF does give you accurate identification of the organisms listed here, including Aeromonas, Campylobacter, Plesiomonas, Salmonella, Vibrio, including Vibrio cholera, and Yersinia enterocolitica. Some caveats when using MALDI-TOF, though. MALDI-TOF cannot differentiate E. coli from Shigella, so you do have to have another method for that. And it also cannot differentiate your, if you want to call it resident flora E. coli, from Shiga toxin producing E. coli. Also important to remember that the media type can affect your identification. Things like blood and McConkie, definitely better than media like hectoin and SS agar. Now, what about performing antimicrobial susceptibility testing? Now, we know that antimicrobials are not routinely indicated in healthy patients with self-limited bacterial gastroenteritis. So, for the most part, routine susceptibility testing of stool culture isolates is not indicated. Now, some exceptions may be in infants, especially young children with very severe disease, the elderly or immunocompromised, those with prolonged disease, and those in which we isolate Salmonella typhi or paratyphi. Now, remember with Salmonella, even though we're not recommending routine susceptibility testing of isolates from stool cultures, any extra intestinal isolates of Salmonella should receive susceptibility testing. What about result reporting? For our positive cultures, obviously, the pathogen and, if it's appropriate, susceptibility testing. For our negative cultures, it's very important that we let our physicians know what we've actually looked for in our cultures. Not just no enteric pathogens isolated, but very specifically that we cultured for Salmonella, Shigella, and Campylobacter, and it was negative for all three. Obviously, verbal reporting or some kind of automated electronic alerts to healthcare providers is also helpful, especially in the case of something like Shiga toxin producing E. coli, and also rapid reporting to our public health colleagues, forwarding isolates as appropriate for your particular state, or in the case of S-Tech enrichment broths, so that public health labs can perform testing. Okay, so now lastly for the elephant in the room. The question is, do you perform or are you going to perform a multiplex molecular panel instead of stool culture? Are you somebody who is like, yes, I've already switched, I'm not doing any stool cultures? Are you somebody who's, well, I've switched, but I only do a molecular panel, say maybe for Salmonella, Shigella, and Campylobacter, so if I have a request for Vibrio or Yersinia, I'm still going to use culture? Are you somebody who hasn't switched yet but wants to? Or are you somebody who hasn't switched and plans not to? Well, pretty much the future is now. We now have 5 currently approved, FDA-approved assays for detection of not only bacterial pathogens, but also parasites and viruses. You can see that they're listed here in this slide. And as far as their ease of use, essentially that's my concept of their ease of use. Basically, what I would look for in my laboratory in bringing in a test like this is whether or not everybody in my laboratory could perform the test. And right now, pretty much the Luminex assay and the Hologic assay would have to be performed in a molecular laboratory and would not be able to be performed potentially by everybody. Whereas the BD Max assay, the Nanosphere Verigene assay, and the BioFire Film Array assay are ones that could be performed by essentially all shifts of technologists in your laboratory. So again, what's available on these assays, you can see that there's a huge variety in what the assays offer. For instance, the BD folks with their BD Max assay have chosen to compartmentalize testing. So their assay right now is available for Salmonella, Shigella, and enteroinvasive E. coli, Campylobacter, and Shiga toxin, detection of the Shiga toxin gene. Whereas something like the Film Array looks for those pathogens as well as a significant number of viruses, parasites, and other bacteria as well. So again, it's pretty much up to you which assay you would want to choose based on what you would expect to find in your patient population. So the question is, will nucleic acid amplification assays replace culture and other antigen or toxin testing? They do have a high sensitivity. They're fast. Again, they do have that multiplex capability, so you're not only looking for just bacterial pathogens in some of those assays, you're also looking for parasites and viruses. But again, they are associated with the cost. And some people may think that the cost is more than they want to bear for the results that they get. Also, you have to think about what is going to be the impact of this culture-independent testing on our public health surveillance for these organisms. Essentially, when we begin, if we choose to begin doing nucleic acid amplification testing, we will no longer have an isolate to submit for serotyping or susceptibility testing if requested. Now, this also, depending on what state you're in, may impact your reporting to public health by not having an isolate available. So, conclusions. The number and types of agents that we're going to look for in our stool cultures should be driven by our geographic location and our patient history and patient population. We can use chromogenic media to help make our culture workup easier. We can also use MultiTOF as an alternative to our traditional workup algorithm. Also, according to the CDC, culture for both E. coli O157 as well as testing for non-O157 STECs is the best practice for detection of the Shiga toxin producing E. coli. So remember, if you choose to use a more selective approach and only test upon request, again, make sure that you're also looking at multiple screening criteria. Also remember that effective communication with our clinicians regarding the need for culture for those emerging pathogens as well as susceptibility testing is a must, right? And also, again, we want to make sure that our physicians know what we're looking for in our routine stool cultures. Now, still to be determined is what's going to be the role of stool culture in the era of nucleic acid amplification testing. Again, decisions that people need to make are, is the cost worth it for me to do nucleic acid amplification testing? What kind of expertise am I going to need in order to be able to perform testing? Am I going to want to perform a more batched molecular assay, or am I going to want to perform an assay that can be done by all of the technologists in the laboratory? What's the extent of testing required? Do I need to know that a patient has sapovirus in their stool? Or is it more important for me to know the basic Salmonella, Shigella, Campylobacter, and STEC? Also, again, the potential for the lack of availability of isolates for additional testing by our public health colleagues. Thank you very much for your attention. I'll be happy to take any questions if you have any, but I appreciate you being with us today.